Health. We are expecting Dr. Ram Raju to join us, and we will note for the record when he arrives. But we have a quorum and we will begin. I have the time at about 10 o'clock. Our first item of business today is to review and approve the minutes from the meeting held on December 6th. We did not have a meeting. We have not had a meeting in the interim. I will turn to my usual reviewers. Dr. Foreman, do you have any comments? And then Ms. Redlander.
Thank you. Very few. I only found a couple things I thought were worth noting. I believe on both page 12 and 14, 12 and 16, there's a reference to the TCR test, like we meant PCR. PCR in most other places, but those two.
That's correct.
And then there was one sentence on page 14, which I think was not entirely correct. It's lines 8 through 10. I think it should read something like, or 9 and 10, so that the broth only needs to be submitted if that's the culture medium in which it's formed, not the if is in the wrong place.
That's, yes, that's clear.
That was about the culture block for enteric pathogens. Those are the only substitutes.
Any other comments from the board? I had one on page 21, line 4, holding members of the Board of Health in high regard. Commissioner Redlander is not accurate. With that, may I have a vote for the approval of the minutes? All in favor, please say yes. Yes.
Yes.
Yes. The minutes are approved unanimously. We have today 4 proposals for publication for amendments to the health code. All of these are for publication, and they would be open for public comment if the board approves them for publication today. The first one is the proposed resolution to amend Article 13 of the New York City Health Code. This regards hepatitis C RNA testing. We have a presentation on this proposed amendment. Dr. Daskalakis and your team, if you could introduce yourself for the record.
My name is, I'm Dimitri Daskalakis, the Deputy Commissioner for Disease Control. Thank you very much for allowing us to present. As Dr. Bassett said, this is a proposal to amend Health Code Article 13 for disease surveillance. Article 13 regulates the manner in which lab tests be performed and reported to the Department of Health. This is a very specific proposal related to hepatitis C. By way of background, 150,000 New York City residents are estimated to be living with hepatitis C infection. We also know that nationally, HCV is a leading cause of liver cancer and liver failure, accounting for more deaths annually now than HIV. We also know that rates of liver cancer among men in New York City nearly tripled between 1976 and 2013, while rates for women in the same time period doubled, posing really that hepatitis C is a significant threat to the public health. Before we talk about lab testing, I just want to remind you what happens after a hepatitis C infection. If someone is infected with hepatitis C, 25% of them are able to resolve the infection on their own within 6 months. That is the minority. 75% go on to have chronic infection established in their body. Lab testing is the only way to differentiate if someone has cleared their hepatitis C infection or if they have gone on to the chronic stage of disease. So generally, appropriate hepatitis C testing involves 2 steps. The first step is an antibody screening test, which shows whether the patient has ever been infected. The result is positive or negative and a serology. If the antibody test is positive, a confirmatory RNA test is necessary to establish if the individual is one of the 75% with chronic infection. If a confirmatory RNA test is not ordered at the time of the initial test, the patient has to return for testing and repeat blood draw is necessary to be able to do that test. The multi-step testing process results in diagnosis and treatment delays and patients being lost to care. Looking at our surveillance in 2015, 22% of New York City patients newly reported as hepatitis C virus antibody positive had never received RNA testing for this infection. So 22% were actually aware if they were acute or chronically infected. That means that 78% don't know if they actually have active Hep C or if they are, excuse me, or if they have cleared the infection. So the proposal is to amend health codes to require the laboratories to perform a routine confirmatory RNA HCV test when there is a positive HCV serology or antibody test. This is analogous to what happens with HIV. If someone comes in and has a lab-based test for HIV and the antibody is positive, further testing is done as a matter of routine linked to that positive test to identify if they have a true positive or a false positive. This helps to ensure in HIV and now potentially in hepatitis C that individuals who are infected with this virus are aware of their status, linked to appropriate medical care, treatment, and now cured to improve their health and also reduce the risk of transmission to others. Thank you.
Thank you. The presentation is now open to questions from the board. Are there any questions? Comments? Wow, thank you. That's quite clear. It was very clear.
Thanks to the disease control team for putting all that together for me.
Thank you. Can I have a motion to approve for publication this amendment to Article 13?
So moved.
And a second? Second. All in favor, please say yes.
Yes.
That was unanimous, no abstentions or opposition. The amendment is approved for publication. Thank you, Dr. Daskalakis. Then we'll move on to a proposal to amend Article 3 of the New York City Health Code regarding monetary penalties. This one will be presented by our General Counsel, Tom Merrill.
So Article 3 of the Health Code is with the general provisions for the Health Code are, and you may, those of you who've been on it for a while may remember we did an overhaul of the Health Code about 10 years ago and addressed some of our core powers in this. What we're proposing today is to amend Section 305, which is the penalty provision, civil enforcement of the Health Code, to add enhanced penalties in certain discrete situations. Currently, the maximum civil penalty for a violation of the Health Code is $2,000. That was set in, I believe, 2003. That will still be the cap and the standard range for most violations of the Health Code will continue to fall within $200,000 to $2,000. What we're proposing today is to provide, in limited instances, enhanced penalties when special aggravating circumstances are present. Those would be in the case of, first of all, a recidivist penalty or violation of a of the Health Code, which would include violation of Commissioner's order of the kind that could have resulted in serious physical injury. And this amendment would allow us, give us the tool to, in that case where there is a repeat violation that poses a substantial risk to injury, to have a penalty of $5,000. The other special situation where we'd be allowed to do an enhanced penalty if this is passed would be in the case where a violation of the Health Code results in serious physical harm. And in that situation, under the amendment, we would be able to seek a penalty of $10,000. Again, this is a tool that we do not anticipate we would use frequently, but It has been some time since the, penalties were set. $2,000 may not be an appropriate penalty in a case where there is a substantial injury. And we feel that this would allow us to have another tool to get for the compliance with the health code. We're modeling this after penalties that are in state public health law for violations of state laws. To give you some examples of situations where we might invoke this, a few years ago, you may remember, we did the order on K2. So if there were, that's just hypothetically, if there had been a store that had violated an order and had sold K2 to someone and that had resulted in serious injury, that would be a situation where we might, then want to go after a higher penalty. Similarly, we regulate daycares, and if there were a tragic case where a child lost and something bad happened, that might be a situation where the higher penalty was warranted. So again, this is something we're not going to do broadly, but it is a power that we're asking you to amend the health code to give us. Any questions?
Thanks very much. I guess the question I have is, particularly for the second example you gave, where there was a serious injury or loss of life, think about these penalties of $10,000 and wonder if that penalty that level of penalty is shown to be successful or effective as a deterrent, or in getting the individual or the daycare center that has violated the rule to actually comply when they wouldn't have otherwise. Is this actually an effective way to, what's the goal of adding, making it a larger penalty? Is the goal to be a deterrent, in which case is this not high enough? Does it work?
The goal is to be a deterrent. Whether it's high enough, I don't, we're modeling ourselves, we're following the lead of the state. I wouldn't want to go beyond the state, so I'm not sure, and we could debate that if this worked. I should also point out that this is in addition to criminal penalties that already exist, so it's an additional tool. Right. We can enforce the health code criminally, and we might do that in a really, really bad case, but this gives us another mechanism which we choose to use in our discretion. And yes, it is just, having that hammer. The goal of a hammer is always to get compliance.
Dr. Richardson. So this would be a maximum penalty of either $5,000 if it was a recidivist, or $10,000 if there was physical harm for each violation. Is it possible to cite multiple violations, or is this sort of the total of a fine regarding any one situation?
It's written as each violation. I'm having a hard time imagining. I suppose.
Well, again, I mean, in daycare center, for example, there might be multiple violations which combine to result in, or in a recidivist case where there are multiple unclear violations. So this would be per violation.
As written, we could alter it if you wanted to. Also, bear in mind we have.
No. I just wanted to be clear that this is the intent, that it is per violation, and so a single violator might actually have fines that amount to more than that if they had multiple violations, and a fine of $5,000 was.
Yes, although you'd have to imagine a scenario where each violation led to that injury. But assuming that happened, possibly. Now again, if we have the discretion, we don't need to charge it that way.
Well, that's for the $10,000. The $5,000 one is simply recidivist, right? It's egregious. So I can easily imagine that there are multiple violations that go uncorrected.
But each violation there too has to be capable of causing serious physical harm. It's not just for any repeat violation. It's only for a repeat violation of an order or a health code provision that could result in serious harm.
I understand. Well, many of the provisions of the health code are to ensure safety, and failing to follow them may well result in harm, which is why we make the rules.
Susan, Dr. Putzman. Thanks. Yeah, I had the same question as Dr. Foreman as to whether there is any evidence that raising the maximum fines, this really marginal amount, is an effective tool in promoting safer conditions. So that is an open question. Maybe we don't have the answer to that, but I just want to acknowledge that. Also, I wondered if you could give us a little bit of a working definition of serious physical injury. Are we talking about an acute injury that has to occur within, a very short period of time, or does it also apply to injuries whose full impact might not manifest themselves until down the road?
Glad you asked that. So to your first point, yes, I think you're right. We will look, if you approve this for publication, I think one of the things we'll look at to see if we can find any evidence of the effect generally probably on fines and behavior, and we'll bring that back in September. In terms of what serious physical harm is, there is an analogous definition in the state penal law, and actually of serious physical injury, and that's not just unique to New York, but in a lot of states, and it's an injury or harm that it results in death or substantial risk of death or protracted impairment of health. So it can be, it doesn't have to be death, but it can be a protracted loss of function of any organ, it can be a protracted disfigurement or a protracted impairment of health. It does not have to be acute. It could be a chronic impairment, but it has to be that protracted impairment of health.
Thank you.
Ms. Redlander?
I'm just interested in understanding if this regulation were to be changed and the fines to be increased, what is the mechanism for informing agencies of this new penalty?
Do you mean agencies or rate? So it would be...
Whoever would be, whoever this is relevant to.
So it's relative to anyone in New York City. So part of that process is this: we're having an open meeting and it will be published and we will take comments on it. We will then also, again, have an open meeting and we have to circulate to the media. We have to, but we will probably reach out to our regulated entities and let them know that there's this new provision. In terms of the public at large though, welcome any suggestions you have on reaching it, but there is that general publication involving the meeting, and that kind of will change it too.
I see, thank you.
Just a comment, the board may not be aware, but we issue a very large number of commissioners' orders every year, something like 27,000. So when it said that we expect this not to occur very often, we're really talking about many, many fewer than that. Most of them arise from environmental conditions related to rodent control and daycare and so forth. Are there any other further questions, Dr. Richardson?
I guess this follows up on my colleagues, but is there any information other than the levels of fines for the states about what other jurisdictions use as fines? Or do you have any sense of, are we in the middle of the pack or on the high end, or is that something you could look into and get back to us? Again, I'm struck that I'm not convinced these numbers are high enough to be a substantial deterrent, particularly for businesses. And I wonder, is this, I understand modeling after the state, but I just wonder what other jurisdictions may be using.
Sure, we'll definitely look into that.
All right, then once again, this is a proposal to publish this amendment that would result in a public comment period. We treat the questions from the board as part of our public comments. May I have then a motion to approve for publication the resolution to amend Article 3? And a second. Dr. Kara, thank you. All in favor, please say yes.
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 No abstentions or noes. The motion passes unanimously, and we have approved for publication the amendment, proposed amendment 3. This moves us on to a proposal to amend Article 161. This regards service tags, but for animals.
Hello.
If you could identify yourselves.
Hi, I'm Mario Merlino. I'm the Assistant Commissioner for Veterinary and Pest Control Services.
And I'm Alexis Cuffey, I'm the Director of Pest Control Property Research and Dog Licensing.
Good morning.
That's it.
Sure. Sorry about that. Okay,
What we are proposing is an elimination of the service dog tag. We're also proposing to do two other items which will be addressed by someone else. The service dog tag is something that the agency has been issuing for quite some time. In 2010, there was an amendment to the health code to actually provide a service tag to those individuals who have animals with dogs, specifically with disabilities. The amendment was well-meaning. It was meant to make it easier for someone with a service dog going into any type of facility to have the dog readily identified. What has happened in the interim is that the agency has become the, shall I say, the institution that is certifying service dogs for these individuals. And the public has a misconception that we are supposed to give out a tag, that the dog will not be recognized as a service dog without this tag. And that is totally incorrect. The Americans with Disabilities Act clearly states that it is not necessary to have any type of identification, be it tag, vest, whatever, to identify your dog as a service dog. And that, in fact, there are only two things that can be asked of you if you're an individual with a disability. Is the dog a service dog? And what is the dog trained to do? That is the only information that you need to provide. Yet we are finding that we have many institutions, be there schools, be there public transportation, restaurants that are denying access to individuals without this tag. What it is meant for us is that we are inundated with requests daily for people getting a tag for their dogs. The other issue with that is there are many people who have emotional support animals. And they think because it's an emotional support animal, it is a service dog. The ADA clearly defines that as not being a service animal, it's closer to a pet. So with that, we have a huge task of trying to get people to understand that you don't need to tag, first of all. And second of all, to let those people who know that they have an emotional animal, that they are covered in other ways. So what we are proposing is eliminating our distribution of the tag so that it will not confuse the public any longer, so that they can go to these institutions with their animals and not being told that they must have a tag. So the elimination of the tag will make it easier. We will be having an education process for the institutions, the public places, so that they will understand what the ADA's position is on this and what they need to do or not do with a service dog. We do have information currently on the health department's website under service dogs where there are flyers. This particular flyer comes from the mayor's office for people with disability. They were gracious enough to provide this information for us. So that particular flyer does explain to an individual what they can and cannot do, and it also explains that certain cases where the dog can be removed if it is not behaving or if they don't have control of it. We also have another flyer which is provided by food safety. That information is for the restaurant owners because we get a lot of calls about that from them, wondering what their rights are or what they must do to comply. So we feel that this would be the best course of action for the agency, and it would make it easier for the public as well.
Thank you very much. Does that conclude your presentation?
Yes, it does.
Open for questions. Dr. Klitzman.
Thank you. I totally understand the reasons for proposing this change. It does make sense to me. I just wanted to get a little bit better understanding. How often does it happen, or does it happen, that people with a service dog are denied access to public facilities, or they're told, we can't let you in unless you show the tag for the dog? How much misinformation is out there?
It's quite frequent. As a matter of fact, just last week, we got some communication from a reporter from a public station telling us that he had been contacted by a parent of a student in a school in Queens who was denied access for her son with the service dog because the school said to her that the health department had to approve the dog as a service dog. And this is a professionally trained service dog, which is very expensive.
So it sounds like there is a big need to do more public education and information campaigns, even if you weren't going to make this change, because there's a lot of misunderstanding of what the regulations are out there. Is that correct?
Yes, well, we will be planning to do some type of public service information for the owners who have tags. Should this go through, we will be informing them that, the tag is no longer necessary. We're going to ask them to remove it from the dog's collar. We're also going to have our call center have certain information that if someone calls, our call center calls 311 and they get to the call center, explaining to them what they can and cannot do, and we're going to be doing an information training.
No, sorry, and we also work with the Mayor's Office of People with Disability and the Commission for Human Rights in the Mayor's Office, and coordinate with them as well. And they have a website and hotlines as well. And they're really the entities responsible for enforcing these rules with the public. And I think it's important that people understand their rights. They have a right to, they have a service animal, they have a right to access to public facilities, and that those entities are the entities that can help make sure to enforce those rights. So anyway, to answer your question, I think you're right, a press release and website and that sort of thing to get the message out.
Please.
So, I'm certainly familiar with the traditional categories of service animals, but in recent years there seem to be a number of health-related functions that animals are being trained for, things like diabetic patients having dogs who can alert them to when their sugar is high, or patients who, or individuals who have serious allergies, and there are dogs who I understand can be identified to, can be trained to identify various substances. Does this kind of thing count as a disability, and are these sorts of dogs considered service animals or support animals?
Yes. Yes, they do count as service dogs because those are bona fide disabilities. The issue with the service dog is the dog has to be trained to do a specific task. It is not a pet. So the dog trained to perhaps recognize a peanut allergy. That person would have a service dog because the dog is going to have to detect trace peanuts in the food, or someone that has a diabetes. This dog is trained to recognize blood sugar levels. That is a service dog.
Because we think of those as, at least as a physician, as diseases rather than disabilities. So the difference between service and support is really a physical ailment, disease, disability, which separates it from an emotional support dog, which is for to support an emotional or behavioral condition. Is that the distinction between support and service?
Yes, that is the distinction.
Is that somewhere codified in law?
The definition of service animals in the American Disabilities Act, and it's exactly that. It's a dog that works. It's a dog that's been trained to do a function. It's a support animal that makes you feel better, but it's just because of that. The ADA requires that the dog be trained to do something.
I've heard of service dogs that have been trained to detect early onset seizure disorders, for example. But I think Dr. Richardson's raising an interesting point that if somebody is seriously disabled by some emotional condition, then in what way would that be acknowledged as a disability? Can you comment on that?
Yes, in that case, the dog would have to be trained to mitigate a circumstance. So say if someone has an emotional issue that causes them to do self-harm, the dog would be trained to recognize when the person was going into that state and to interrupt the behavior. That's considered being trained to do a function, and that's a service dog.
So it's a trained working animal.
Yes.
I want to mention, we had a colleague from MOPD who is available to answer questions about this. Did you want to have him answer this question, or?
It's up to the board. Dr. Interested? Dr. Foreman has a different question, and then we'll see whether a comment would be useful from our sister agency. Thank you.
Yeah, thank you very much. I think the distinction that the service animal is trained to do something specific makes sense. There's two things I wanted to ask about. One is who determines on a national basis what constitutes an action in the pet, and what's the extent of training? I presume that's fairly vague, and who does the training, and so you could see a slippery slope with what's a service animal and what's an emotional support animal. But my real question is about, because I don't remember, was the initial intent of the tags, because I presume there must have been an issue with members of the community gaining access with service animals to public spaces and public facilities. And we don't always get it right, and clearly it appears that hasn't worked, but what I'm hearing is mostly anecdotal evidence that it's not working, and you're being burdened in two ways: people asking appropriately for tags, and people asking inappropriately for tags, and you have to explain over and over what a service animal is and what an emotional support animal is, which is a large burden on the agency. But I'm wondering if there's any data in terms of to drive this as opposed to anecdotal reports. Limitation of access, inappropriate requests, something more than just, it felt like it wasn't working before, so we tried this, and now this isn't working, so we want to stop.
The tags predate, or our issuance of the tags predate the American with Disability Act, we think. We took over issuing dog licenses from the ASPCA in the mid-90s, 1995. So the ADA is 1990. And I think the regulations, the current regulations, guidance is a little bit after that, but the ADA is 1990. I believe, and I couldn't quite research this because we don't have records that obviously predate our administration of the dog license, but I think the ASPCA was handing out these tags well before we took it over in 1995. So my feeling is these tags were probably very useful prior to the ADA. When that was the only game in town, and there's an obvious need for, people to have something that would allow them into an establishment with their service animal. So I think it made a lot more sense prior to the ADA. At this point now, we're actually conflicting with the ADA. The ADA specifically says that you don't need any kind of tag or certificate from anyone to have a service animal. You have a right to bring your service animal to these a place of public accommodation. So our issuance of tag actually conflicts with the ADA. In terms of your point about how many tags are we issuing compared to how many we are, how many requests we're getting. We're issuing about 200 tags a year. We're getting many, a little bit less than 200 tags a year. We're getting many multiples of that requests for tags for comfort animals. And many of those tag requests, I should say, are related to issues around housing. People have a lot of conflicts with their landlord and their comfort animals. And the thing about that is those rules are different from the ADA and how you're allowed to have a comfort animal in housing. So again, you don't need a tag, and it's a different rule, and the comfort animal thing works for housing. And what you really need to do is you need to contact the MOPD and the Commission on Human Rights and pursue that, and you can pursue that as a civil rights case if you have a comfort animal. And again, having the tag and needing the tag, has nothing to do with enforcing that. So again, it's just tags that could do that. But we could provide, I think, some of those. We might not have great data on how many we turn down, but it's a fairly large number. We get requests every day from people with comfort animals. And how do you tell the difference? People aren't very sophisticated when they approach us, and they'll say it's a comfort animal. People can game the system if they want. The ADA regulations probably allow it, but most people are not that sophisticated, and they'll say it helped the animal's helping with my anxiety, and that's a compliment.
Thank you. Ms. Fredliner.
I'm sorry, it's a very interesting topic. I'm just trying to understand, make sure that I understand the categories. So there's a trained animals to support an individual with a medical condition. There's a category of comfort animal, and then there's pets. Is that true? There's sort of three categories, and there's something very specific around a comfort animal category, or just how people feel?
Well, I think that none of these things are mutually exclusive. I think your pet can be your service animal, could also be comfort animal. But I think you can. But I think what you just said is more or less accurate. You can. But in terms of the law and rules, there is housing law. Housing law mentions the term comfort animal, and if you have a comfort animal, and it meets the definition in housing law, you're allowed to have that animal, even though your lease says you're not allowed to have an animal. So that's what it's about. So it's about meeting the terms in those rules, and that's HUD regulations and housing law and all that kind of thing. The service animal is an ADA, is American with Disability Act regulations, and then we have our service dog tags, which is in the health code.
Right.
Which is conflicts with all these other.
Which is not necessary.
Which is not necessary.
For an ADA.
Confusing everything.
And then just to follow up on Dr. Foreman's question about the training for service animals, is there a particular organization or that certifies the training?
There is no. I'm glad you brought that up. There is no training requirement, and also when people are claiming to have a service animal, you as the owner of this establishment are not allowed to assess the training and ask for training, anything about training. You're only allowed to ask what the task is that the animal does. The animals can be trained, can be home trained by the owner even. Many times they're not, but there is no requirement that the animal be certified, and that's a big misconception, that there's some specialized official training that animals have to have. That's just not the case.
But a person with a service dog can be asked, is your animal trained, and whether you trained them at home or they were trained by some expert.
What are they trained to do?
You can say yes.
Correct, and that document that's appearing on the screen kind of goes over this. The two things are, what does the animal do? Is it trained, and what does the animal do? Right, those are the two things. And the operator can essentially, assess, is this really, a service animal? And make a decision to allow the animal. It has to be a dog, by the way. There's no such thing as any other kind of service animal. There's no such thing as other types of animals being service animals. There's no such thing as service cats. Not true with comfort animals. You could have other types of animals be comfort animals. It's a different story. Not what this hearing is about. But the thing is, the operator has to make a decision not to allow it. If the operator decides not to allow it, and the person decides to pursue a case, again with the Human Rights Commission, decides to sue, and that becomes a civil case, there could be substantial penalty. So I think the law is really written in such a way, as all civil rights laws are. If you want to kick someone out of your place, and you have a place of public accommodation, you can do that in that moment, but you have to live with the consequences. That's the deal.
Let me just take a moment to acknowledge that Board Member Rosa Gill and Dr. Ram Raju have arrived, and let the minute reflect that. Thank you. Were there some additional follow-up questions? Dr. Foreman, Dr. Richardson, did you? It's always interesting how the animals so dominate our conversation.
No, it's fascinating, but irrelevant to the question before us.
Thank you. Just a quick follow-up question. So what you just said was that an operator facility has to make a judgment and can deny access if they don't believe that it's really a service animal. So if they don't believe the answers essentially these questions. And what you seemed to imply was the only recourse is to sue. Is there any other recourse through the Department of Health or through the city that a citizen could take if they felt they were inappropriately denied access, other than a court case, which is hard to beat?
The Human Rights Commission enforces, and there's fines, and also there's a state Human Rights Commission, there's penalty, and the federal government as well. They can issue fines, and the fines are very substantial.
And then my other very quick question, although not relevant to this, is you mentioned that housing law, HUD, defines comfort animal. I'm just curious if anybody knows what that definition is.
I don't have it at hand, but it is a broader definition, and it's an animal that brings you comfort. Also, the flying laws as well. So you can bring a comfort animal onto planes, you can live with a comfort animal, but in the, for accommodations and services in the public, it's a service animal.
All right, are there further questions from the board on this proposal?
Okay, I just mention one thing. The other thing that you have to do, the operator has the right to use entry if the person is not maintaining control.
Dr. Kyle.
I encounter one more often, even hospital allow comfort animal when patients are recovering from trauma, injury, etc.
But the question really before the board and the department is really about eliminating the need for the tags.
That is correct.
To be in alignment with the law.
That is correct. And several reasons have been offered. Dr. Foreman had noted that the department is trying to put itself in the position of adjudicating whether animals are comfort or not. But importantly, the requirement for a tag is not specified in the American Disabilities Act, and the people have the right to these dogs without tags, so that this part of our health code is a source of confusion. I have heard from the comments that we both need to educate individuals as to what a service dog is, and the types of institutions that might be asked to determine whether or not a dog should be permitted entry. So we have two targets for educational work, and I appreciate the way this came to the fore in this conversation. But if there are no further comments or questions for the team that is presented today, may I ask for a motion to approve for publication the amendment to Article 161 regarding service tags for dogs.
So moved.
And a second? Ms. Redlener, all in favor, please say yes.
Yes.
I took that as unanimous. Am I correct? The motion is to publish this for public comment is approved unanimously. Thank you very much.
We have just 3 other.
You're the same crew.
But the same-
All right,
but
let's
these are,
keep
I've
going.
been told that we're behind, so I can do these very quickly.
Sure.
These are just 3 wording changes that are, we're trying to, be more protective. So very, very quickly, 161, 15D, we want to, where it says prohibit sale and holding for sale, boarding, grooming, training of any dog or cat that has been exposed to a communicable disease. We want to switch out dog or cat for all animals to make it more protective, so not restricted to all animals. 161.17, we want to add, it says free of other diseases. We want to expand that to include, it says other diseases, we want to expand that to include free from parasites as well. So we're adding communicable diseases with parasites. So expanding the definition to include parasites. And then the third thing is to change, to clarify, and again, this is not, we're not actually changing the requirement here. We're just clarifying that in 161.15 it talks about a room in which a person, we don't have the code section, but a room in which a person lives cannot be used as a boarding facility, right? So it's in our definition, 161.15, a room in which a person lives cannot be a boarding facility. We want to switch out room for dwelling, and the point of that is people have disputed and said, I can do animal boarding in my house as long as I keep it to a particular room. And actually, that's not the intent of the health code. The health code always banned doing boarding as a home business, and in fact, that is consistent with New York City zoning law, which bans animal boarding as a home business. And you can imagine, people trying to do boarding in apartment buildings and that sort of thing. It's probably not a good idea. So again, that doesn't change how we have enforced it or what the intent was. We're switching the word room for dwelling just to kind of clarify that that's
Sure, thanks. So to the board, it seems I asked for a motion to approve prematurely. We have these 3 additional wording changes to discuss. Are there any comments or questions about these? Hearing none, then I will ask you once again to
I remake my motion.
remake my
Approve for
motion
publication.
to approve for publication, Article 161. Thank you.
Yes.
Remake my second.
Revote.
Yes.
So it passes unanimously. Thank you very much.
Thank you.
We now move on to the 5th item on our agenda today, which is a proposed resolution to amend Article 47, which regulates childcare services under the New York City Health Code. If you could identify yourselves for the record. Good morning.
Hi. Good morning. I'm Frank Mishula, Assistant Commissioner for the Bureau of Child Care. Hi, I'm Kelvin Chan, Director for Early Childhood Development at the Bureau of Child Care. So, we're here today seeking the board's approval for publication of revision to Article 47. The department is proposing a new permit category for drop-off child supervision services based in family homeless shelters. So currently, the state law requires family shelters to provide child care in order to qualify as a Tier 2 shelter. Child care can be provided by way of a drop-off service within the shelter, caring for just the shelter residents, or by way of a linkage agreement with a licensed child care service. Staff are required to have minimal qualifications, some child care experience, and some training. There are no requirements for background checks, physical space, or safety standards. So we're proposing a new section in Article 47 for family shelter-based child care services that would be known as drop-off child supervision programs. We would also be establishing new requirements for staffing, and we would be enforcing the existing requirements in Article 47 relative to physical space, health and safety standards, and programmatic requirements. These programs would be defined as being operated by or through contract with DHS. They would serve the children of the shelter who are under 6 years of age, and we would limit the hours of care to no more than 10 hours per week per child. As far as staffing, we would have a new requirement for a child care liaison who would need a BA degree, and that would manage the staff of the drop-off service, and arrange for in-service training, as well as refer families to licensed child care programs and help them with applying for seats. The child supervisor would need either an associate's degree or CDA, a Child Development Associate certification, and they would directly supervise the children within the drop-off service. As far as staff-to-child ratios, we would require 1 staff to every 8 children, and that's for children between the ages of 3 to 6 years. And for under age 3, we would have 1 staff for every 4 children. In addition to the qualifications for the child supervisors, we would require training in mental health first aid, social emotional learning, and family engagement. And like I said, the other parts of Article 47 for physical plant would apply as far as CFOs, fire department inspections, secondary egress, lead testing, floor restrictions, safety plans, and full clearances for all staff. So we're happy to take any questions you may have.
Thank you, Frank. Just to give you an overview, the intent of this is to bring under regulation a previously unregulated child supervision activity within these shelters, and to enhance the safety and quality of the service that is provided. These are not considered child care centers. It's child care supervision is used intentionally to refer to something more akin to babysitting than being a child care. So with those comments, I'm happy to entertain questions. Dr. Raju, Dr. Ramon.
Is there a time frame in which you are going to you're going to create a ramp for these people to be certified, or is it going to be on a particular date everybody should be certified? Then if that's the second one, how many of those centers right now, so-called centers, will need to be closed?
So as far as time frames, what we have is sort of unique. We have a system that's already operating and already providing services that we're now looking to regulate. So of course, we will work with the programs over the course of the coming year to get them permitted. We'll have to make allowances for existing staff as far as their certification and give them adequate time to become certified, especially if they're going for their CDA. That's a 1 to 2 year process. So we will issue the permits with a modification in place as far as that qualification for the child supervisors. As far as how many of these programs may need to close, none of them would have to close based on the regulatory proposal that we have, except for those programs without things such as secondary egress. And if they're not able to put in a secondary egress, they will in fact need to close.
Yes, please.
Thank you. I just want to share with the board that I have been working with an organization called the Children's Health Fund, whose initial mission was to provide health services at family shelters. So I would like to step back a little bit from the concept of establishing, with the goal of establishing criteria for the daycare centers, which I think is a positive thing. I am in support of improving safety and standards for agencies that care for children. But as I see this, and please correct me if I'm wrong, we are proposing to limit some of the services that are now provided in family shelters to being available to 10 hours per week for families. At the same time, we are proposing to increase the qualifications and expectations for those services. Is that correct?
So I think specifically we're looking to limit the child supervision service. I don't think that this would impact health services to children.
No, not health
or anything
services.
that-
I'm talking about the training and the other criteria. So right now, there are quite a few shelters that have full-time on-site daycare defined loosely for families that are in shelters. And what this proposal will do is limit access to those services to 10 hours per week for families.
So for the program.
Because it's falling under the drop-off
Right.
definition of services.
But also programs that are currently operating a full childcare service can also apply for an Article 47 permit. They would just need to meet the enhanced requirements of Article 47.
Right.
Right.
So do the Article 47 standards, which you have listed on this presentation, apply to the drop-off category of services
The
as well?
physical plant requirements, yes, not the staff qualification
The-
requirements. It's very different than an Article 47 childcare site.
So a homeless shelter would have the option of having a drop-off center where the staff don't have to be as trained, but certain standards have to be met, which is only available for families for 10 hours per week. Or a daycare center under Article 47, which would be a full-time service available for families.
Yes, they do have that option.
The other option, just to clarify, is community-based services. And I think that the map that's been put up was,
What this map is showing you are the number of community-based licensed programs around each shelter. The DHS shelter is represented by the orange dot in the middle, and that's a half-mile ratio showing, radius showing all of the child care programs within the community that the children could be enrolled in.
I think there are just a number of questions here about what families living in homeless shelters need in order to take care of the requirements that they have for work, for school, for getting their children to school. I am very concerned about a regulation that would limit easy access to daycare for families living in shelters. And I appreciate that there could be neighborhood resources in many of the shelter locations, but we all know that easy access is really important in terms of making families' complex lives work. We all know that some of those daycare facilities are full. And there's concern, I have significant concern about the impact of this regulation on what would be available to families living in this very challenging kind of stage of life while they're trying to get back on their feet, get housing, get training, get work, get their kids to school. We have had a lot of experience with families who try to keep their children in school in their home districts. Well, what this requires is for the younger children to be dropped off at daycare so the mom can take by subway their child to school and pick them up later in the day. So having 2 hours a day of drop-off services to me is not meeting the needs of families in homeless shelters. And that is kind of a larger concern than the regulations that we're talking about.
Right, so, and again, just to keep in mind, we're at the point of public comment, and based on the feedback that we receive, we could always revisit the 10 hours. But let me say this, up until now, the focus really has not been on preschool-age children and the experiences that they're having in homelessness during the day. Because you're right, the parents have to run all over town, they have appointments to meet, they have to get their older children into school. And in our experience, when we went out to these sites, one, very few children were found in these drop-off services while we were on site. Two, very few of the staff knew where the babies were when we asked. And I think that we need to know what type of experience these little young children are going through during the day. So this is being set up again. The drop-off services were never intended to be what we would consider childcare today, which is early education. So what we're trying to do is strike that balance where the younger children are getting some benefit from the program within the shelter, but then for the longer term care, enroll them in a nearby shelter, in a nearby childcare center. Also on the map, we've identified ACS Early Learn sites that are within the neighborhood. And we're continuing to do analysis on availability of care in each of these neighborhoods. And ACS has shared that they do have empty seats for these children, and this is why we incorporated the role of the liaison, to at least put the focus on the preschool-age children, because again, there is so much going on, and our fear is that these younger children just aren't being served adequately during their time in shelter.
Well, I understand, I think that is a very good goal, and if that can be accomplished, through this discussion and through some changes in standards, I would be very supportive. I'm just wondering if you've gotten input from shelter directors about the impact that this change would have on their support for families?
No. Our visits were sort of boxed as exploratory visits, which is what they were. We weren't going out citing violations and saying, you're going to be regulated, we weren't very sure at the time. So I think now, once we inform them of the proposed regulations, and they will get a copy of the proposal, we'll be able to have their feedback, and we'll get a better sense of where they are as far as preparedness and staffing to meet some of these regulations. And the department's going to work with them, as we go forward.
Well, I think that would be very important to incorporate in the language of this plan, is that, to look at where shelters are currently, and as my colleague here suggested, to really talk about an interim plan, support for shelters to implement higher standards and maybe full-time availability on site if that's required, something that was needed in the larger shelters. There are different size shelters, so in terms of, how many children are available in, for daycare in that facility, would vary if it's for 40 families or 120 families, that type of thing. So I think there's a lot to be thinking about, but my concern is that, all of a sudden there's not a very sort of limited availability for support and care of families who are really trying to manage so much during their time of homelessness.
Thank you, Ms. Magdalena. I think that rather than respond to that, which I take as a comment, that we should move on to other questions and comments from the board. Dr. Foreman and Dr. Richardson both have questions. Dr. Foreman.
Thank you, and I agree. I shared some of those concerns. I sort of see two different issues. One is the availability of services in terms of hours per week, and then there's what is the purpose of the drop-off centers in these shelters. So I presume the department has gathered some more robust data on how many children are in these. You said you've made many visits, so again, sort of in keeping with my comment on one of the previous proposals, I think some more robust data about what the current state is, where these exist, how many children come, how many hours per week does the average family actually use, and what's the range of hours needed, so that because otherwise 10 hours seems like an arbitrary number, and it might be appropriate or it might be very inappropriate and limit access. And then so that's just a comment that I presume there is a lot more data there that we just need to hear about that will help inform the decision of the board. My other question is, I also wonder if there's something that spurred these visits and this proposal. Were there any particular incidents, has something happened that this is in part a reaction to, where children were really, we need to be aware of, that children were really getting suboptimal care, that there were adverse outcomes. Often in my experience, something happens that spurs this sort of exploratory investigation and leads to regulation. So the question I'm asking, is there something hidden there?
And there was no specific incident. I think this was just as part of DSS's and DHS's review of their services and their desire to provide better home services. They formed a task force that was comprised of DHS, DOH, ACS, and HRA to look at the child care services within these facilities. So we've been actually meeting and thinking about this and proposed to City Hall back in November, sort of an overarching plan to improve services to young children in the facilities, and this is one part of it.
And I think framing this as the goal is to improve. I mean, why should kids in homeless shelters not get the same level of service that an actual early childhood education center can provide? And you don't want children that are shunted in repeatedly to drop-off centers when they really could be benefiting much more, and especially if there really are services available that are not being fully utilized. So I just think it's important to really have all of the information and understand what the current state is and what the resources are, and to keep us all aligned on the goal is to make sure these kids get the absolute best and safest child care we can deliver.
Right, and we fully agree with that. You know, we really didn't see the need to recreate an existing structure, especially after we did a lot of this data analysis and saw the capacity within each neighborhood. But then again, there is the need for this drop-off service. In fact, it's a requirement. And as stated, parents at the last minute may have to run somewhere, or they may have to drop off older kids at school out of the neighborhood. So they absolutely need the service. But if children are spending more than X amount of time in drop-off service, then we really do need to provide a better service to them. That experience has to be beneficial to them. So beyond just dealing with their social and emotional needs, we would have to also include education. So what that results in is our recreating the child care system that exists in these neighborhoods within the shelter. And we didn't think that was the wisest way to go.
Dr. Richardson.
Yeah, well, I had some of the same questions that Dr. Foreman did about the numbers and what is the average number of hours that children are spending in these services now. And again, this is not an area that I have a lot of familiarity with. I assume the drop-off services are available free of charge to residents of the shelters. Are there not, I assume, fees associated with the child care that might be available in the communities? Are these, in other words, how accessible are these neighborhood centers? They may have some slots that are available on, you know, based on some sort of income requirements, but are these all available free of charge?
Well, so they would either be in an ACS contracted site, which of course, you know, they would be free of charge, or they would have to receive a voucher. So it would be based on availability of vouchers within these neighborhoods. But again,
Right, so
they all qualify for vouchers, they all qualify, the majority qualify for vouchers,
Absolutely.
they all qualify for the ACS.
But the
That's not-
process of even obtaining the voucher may require an absence of more than 2 hours. I have I very much like the idea of upgrading the standards. I have the same concern about the limitation of hours, even to get older children to school. Could easily take more than an hour in the morning to get there and back, and then in the afternoon to go. So they're already over the limit. So that does seem to me to be really restrictive. And again, I don't know what it was based on, if that's the definition of a drop-off service, or was it arbitrary?
Again, it's not in the definition of a drop-off service. Our focus was purely on the services being provided to the preschool-aged child. So we didn't want a child just being dropped off in a room that's been carved out of a shelter that doesn't meet any of their needs. So we're trying to limit the exposure there without having the qualifications of a child care center and a teacher in that room, because the child may only be there for a few hours. So, you know, adding that cost really made very little sense. Yeah, so that is sort of our thinking around it.
Dr. Raju and then Dr. Klitzman.
I think I agree with my colleagues that we would very much, I support this because this is a good thing. It kind of brings it to a much higher level of care, and I think they should get it. There's no question about it. I'm very supportive of this. I think when we finally bring this back, we need to have we would like to see an impact analysis. The impact is, what's the present status? How many of them are there and where they are? What's the numbers who have been treated? What would be the present impact, you think, of doing this? And what's the time frame in which you have to get this done? Do they need 3 years or 2 years or whatever it is? If we do the time frame, people don't meet it, what is the projected expectations of how many of these places will eventually close and what will be the impact on them? So we would very much like to see something, a projected impact, what would happen, because I'm sure not 100% of them all going to get into the regulation. Some of them are going to drop off. So I just want to know what the impact is. I don't need it now, but I think when we bring it back, I think we should probably do a detailed impact study on this particular proposal. Thank you.
There are currently 90 contracted sites with the Department of Homeland Services that serves families. And of these, only 43 have drop-off services. And what this amounts to is about service for about 26% of the families in the system. So the drop-off service itself has limited impact on the lives of all the families that are served in total. So in essence, the idea here is to optimize what limited resources there are for the families in the shelter so that it becomes a matter of better liaising with community resources to enhance that transition out of the shelter lifestyle. And unfortunately, there are significant social and political barriers that keep families stuck in these settings. And the idea to reinforce the liaison role is really to remove those barriers to community resources for transition back into community life.
No, I don't disagree. They got a great impact. There's no question. I'm saying that if the 26% of the people are reducing the services, there is a reason behind it, right? We need to know what the reasons are and what would happen if these 26%, I'm pretty sure some of the places will come up to court and they will do well, and what will be the impact? I'm not saying it's a bad thing, but we need to understand what will be the impact and what happens. There's a reason why they don't go to other centers, because of distance or it's not geography or it's convenience, many factors involved in this. We just need to understand the little. I completely agree with you. I'm sure that you are doing a phenomenal job of trying to get this into a court complaint, which is an admirable task, and I really commend you for that.
I can already say that part of the impact that we're anticipating is greater awareness of where children are in the shelter at different hours of the day. Because one of the questions that we did ask while we did do our inspections of 80 sites back in November was asking the people who were in charge of the service, where are the children? And often the question was, I don't know.
Well,
I just want to reiterate that the role of the health department in this matter is as the regulator. And that our partner in service provision and the assessment of needs of shelter residents, which are wide-ranging and extend beyond childcare and include many issues, is the Department of Homeless Services, which is now part of the Department of Social Services. But I think that the board is being asked to consider a regulation that will have real-world impact. So I in no way want to act as though regulations don't have real-world impact. But I do want to make it clear that we are not the service provider. Neither do we necessarily have a full understanding of the service needs, nor is that our role. Oh, Ms. Gill. And then Dr. Klitz, did I jump you? I'm sorry. Do you see? You see, you go first, Dr. Klitz.
Thank you. I'll just make it brief. One of the themes of the last presentation about the service dogs is, the department and the board trying to find that sweet spot between maximizing health and safety protections and removing obstacles and barriers. And I think that same theme very much applies here in addition to the comments that my colleagues have already made. I just think it would be helpful to us to perhaps, if we could have from you some of the data you've already collected from your inspections to give us a sense of what the landscape looks like, and also to have more input from some of the stakeholders, other service providers and families, and to have a real on-the-ground understanding of what it takes for families to navigate, the situation, so we can understand if what we're proposing is really going to help people or pose more obstacles. So thank you.
Thanks for that comment, Ms. Gill.
I also share same issues with my colleagues. I think in principle this is a very good thing to do to improve the quality of services for children in the shelters. I'm not too sure I understood you saying that there are 90 facilities that have been approved to provide services for families, shelter families, am I correct?
There are currently 90 family shelters that either meet the Tier 2 criteria of this New York State Office of Temporary Disability, OTDA's regulations, or has a contract with the Department of Homeless Services. There are 90 of them, of which 43 have drop-off services.
So those 43, the operators of the shelters, they're also responsible for providing the drop-off services to the kids?
So yes, the answer is yes to that, but in the OTDA regulations, it does not necessarily have to be an on-site service. It could be a matter of liaising with community services.
You have to have all-site.
That was mine.
Right.
And similarly, there are 8 sites that have fully Article 47 permitted programming associated with that organization. So either it's an in-house service, in-house as in it's next door, but it's a fully Article 47 permitted childcare center, or it's the on-site drop-off service, or it's referred out to the community.
Thanks for that clarification. Ms. Redlener.
I have a question. I think in your presentation you said New York state law requires some sort of childcare in family shelters. So
That's in order for them to qualify as a Tier 2 shelter.
Tier 2.
Yes.
So if there are 90 shelters that qualify for Tier 2 and only 43 of them have on-site services, do the other 47 have some sort of childcare?
So
That's different.
it gets very complicated. It's a bit of a learning curve for ourselves in just trying to understand the system. So there are what are known as Tier 2 lookalikes, Tier 2 pendings, and actual Tier 2 certified programs. So what we're referring to are the ones that are actually certified, not the ones that are working toward certification. So that 90 comprises all 3 categories, but the category that we would actually be permitting are the ones that are Tier 2 shelters that have a contract with DHS.
I think that the question was, do all 90 have some form of childcare capacity? And the answer is it's either available on site or they've made some other arrangement. They are required to offer access to childcare to be a Tier 2 shelter. Have I understood that correctly? We're not sure. Well, this really isn't a question for the department, just to be clear. Our charge was to look at the drop-off centers and to consider what the regulatory standards should be for these centers, because frankly, we're motivated by a desire to ensure that just because a child is in shelter, they don't end up sort of sent off to a space that is not appropriate to childcare, where they may sit for hours every day simply in a room. We believe that children in shelter should be entitled to the same level of childcare as children throughout our city. So that was the motivation of framing the drop-off center as sort of a backup child care service that would enable parents to have a safe place to leave their child with an appropriately trained individual for short periods of time. But the goal for sites that don't have on-site, full-fledged daycare centers and have children who need those services should be to find them a place in the community convenient to the parent. I understand that the board would like to hear a lot more about the likelihood that that can be achieved. That would require that we also bring before you the homeless services people who are responsible for these services. And many of these questions will be raised, I expect, not only by you, and as you know, we take all of your questions as part of our public comment, but in the public comment period when service providers will also have the opportunity. There'll be a public hearing, written public comments, will all be opportunities for both people in the shelters, people who provide services to them to raise their questions and concerns. Just to reiterate that, as you're well aware, this administration is very committed to increasing access to housing for people who are homeless, to improving their opportunities to become self-sustaining outside of the shelter system. We also really want to make sure that children have minimized the trauma of homelessness. With that, I want to ask if there are any final questions, because I think in general all of the questions are under the theme of will we do more harm than good by regulating these facilities. It is our belief that ensuring that there's a regulatory standard for any place that a child is kept outside of the home that is safe and appropriate is always for the good, but that is also open to public comment. Last word to you.
Thank you so much for that summary. I appreciate and of course support those goals. But I just have a little technical comment on the summary page for this particular proposal. What are we proposing? In the first paragraph, I think the enhanced certain reporting and disease control requirements may have been left over from some other previous document, and that should be corrected or updated with the proposal that's on.
You're correct.
I think you're correct.
That's a cut and paste error that I think is fine for. So it should, I think, say to regulate, cross out from enhance and change it to regulate child care services in tier 2 homeless shelters.
Thank you for your close reading. A babysitter, I think, would not require such information. All right. If there are no further questions or comments, may I ask for a motion to approve for publication a proposal to amend Article 47 regarding child care services and shelters?
So moved.
And a second. Ms. Gill, and all in favor, please say yes.
Yes.
Any abstentions? Anyone vote no? It is approved unanimously for publication. I expect we will have many comments.
Thank you very much.
All right, we had a long meeting already, but we do want to educate you on some of the work that we're doing, and Dr. Hillary Cunnins has joined us to talk about an issue that is of increasing concern to our department and our city regarding the impact of opioids. Dr. Cunnins, if you could introduce yourself, and we look forward to your presentation.
Hi, my name is Hillary Cunnins. I'm the Assistant Commissioner for the Bureau of Alcohol and Drug Use here at the Health Department. Thanks very much for inviting us. I wanted to speak to you today about the approach that the department is taking to work to turn the opioid epidemic crisis around, share with you some newly updated data which we'll be releasing today, and speak to you about the mayor's recently announced initiative Healing NYC, as well as our specific components that we are responsible for. Overall, this Healing NYC is consistent by and large with the approach that we take to a variety of health problems, and specifically as it relates to opioid use and substance use. We have 6 major themes to our approach that include know what is happening around surveillance and tracking, prevention and reduction of risky use, expanding access to effective care, preventing complications of use, increasing community and recovery supports, and importantly, to work across sectors in a variety of settings. And I'm going to zoom along in the interest of time. As you probably know, the burden of drug overdose, both in New York City and nationally, is really great and unfortunately growing. In New York City, more New Yorkers die from overdose than homicides and motor vehicle crashes combined. Drug overdose is a leading cause of premature death among New York City residents and the top cause of death for younger New York City residents aged 25 to 34. The vast majority of overdoses in New York City involve an opioid, 4 and 5 or 85%. We know also in New York City that overdoses have been increasing every year consecutively for the last 6 years. You can see in front of you a graph with blue bars showing the absolute number of overdoses and the pink line showing the rate. As of 2016, we recently had 1,268 confirmed overdose deaths. The number that we'll be sharing today is we're now up to 1,374 confirmed overdose deaths for 2016, an increase of 937 in 2015. In 2016, heroin, or now fentanyl, are involved in nearly all opioid overdoses. So you can see in the second blue bar, accounting for either heroin or fentanyl, nearly 3/4 of all overdoses involve one of those 2 drugs. In fact, it is the increase in fentanyl in the drug supply that's driving the increases in overdose deaths. You can see in the graph in front of you, the blue bars represent quarters beginning on your left, first quarter of 2015, where the percent in the pink line represent the percent of overdoses involving fentanyl, start from really a negligible amount in early 2015, rising up to nearly 50% in the third quarter of 2016. These data are using toxicologic data from the medical examiner examination of decedents or people who have deemed to have died of overdose. Overdose in some ways is not affecting all New Yorkers equitably, but there are some patterns to call your attention to. Males are disproportionately affected, and it is all people of all races are affected, with whites having the highest rate. And it is a middle-aged problem, with ages 35 to 54 having the highest rates of overdose. You can see on the right in green. And as you all know, it is also not affecting all boroughs equivalently. You can see on the left side with the blue bars representing rates of drug overdose deaths that Staten Island residents have the highest rate of drug overdose deaths, followed by Bronx residents. However, I'll also call your attention to the right side of the slide with the pink bars showing overdose deaths in absolute numbers, with Bronx residents having the largest number of overdose deaths, followed by Brooklyn. And finally, you can see this map, which makes essentially the same point, with highest rates in the neighborhoods outlined in red, affecting both the south and going up sort of the middle of the Bronx, and then the South Beach of Staten Island. So shifting to our response, and you heard about the principles of public health, I want to also just highlight two important principles that really underlie our work here. The first is the very important task of tackling stigma. And here is a quote from Hector, who appears in our a recent ad about naloxone and overdose prevention. In our communities, people are dying. Our brothers, sisters, fathers, mothers, sons, and daughters are dying every day from drug overdoses, but we aren't talking about it. The shame and silence are killing us. So as you know, there is significant stigma related both to substance use and its treatment. And even though we've come very far, there's an ongoing misconception that we hear about when we go out and speak about the issue that substance use is really a moral failing or a failure of character. The words we use reinforce and reflect that stigma, and you've seen them and read them, and I've had some of them up here. And we believe that the consequences and implications of stigma are really great. They impose personal safety risks and also pose real barriers to people's willingness to seek help or to seek help for their friends or loved ones. The other principle I want to highlight here is really here at the department thinking about what we've called the pyramid of use. And we often think of substance use as happening either never or among people who are abstinent, and that's at the bottom of this pyramid, or people who have need of treatment because they have a substance use disorder. And we don't think much of the people in between who may have some periodic use or occasional use, which in the context of overdose is quite important, and particularly in the context of fentanyl, in which a single time of use or occasional use can put somebody at great risk. So as part of the more recent city investment and response, I want to describe Healing NYC. The goal of Healing NYC is to decrease opioid overdoses by an ambitious 35% over the next 5 years. Announced in March of 2017, it represents a $38 million investment at full ramp up. There are 12 overall strategies, and these represent a collaborative effort among multiple agencies. You can see that they're also separated into 4 goals: preventing overdose deaths, preventing opioid misuse and addiction, connecting New Yorkers to effective treatment, and reducing the supply of dangerous opioids. And I'll just, in the interest of time, I'll just spend time on the strategies that the health department is either leading or has a significant role in. So we are taking the lead, and I'll describe in a little bit more detail momentarily, naloxone expansion, which meets goal 1. We are taking the lead on rapid assessment and response, judicious opioid prescribing, setting up a non-fatal overdose response system, conducting public awareness, and improving access to treatment, specifically medication-assisted treatment. So the goal for the naloxone expansion is to ramp up to distributing 100,000 naloxone kits. Naloxone is a medication which you all know reverses the impact of an opioid overdose, restoring a person's breathing. Our aim is to distribute naloxone into high-risk communities and in settings that are likely to encounter folks at risk of overdose. The program will also equip more public safety officers, particularly NYPD. Our aim is also to increase pharmacy distribution and participation in the health department's standing order program. And as you may have recently seen on subways, raise public awareness about the utility and access to naloxone. We, as part of that awareness raising effort, we just recently released a mobile application where anyone, and I encourage you all to download the application either for your iPhone or Android, we will help you learn to recognize and respond to an overdose and find nearby programs that supply naloxone. As a second effort, we are launching a rapid and assessment and response capacity. We have an ability to detect new trends or changes and an ability to go to communities to assess more completely what has been happening. The components of this effort will include real-time surveillance, rapid assessment using both quantitative and qualitative techniques, and to deploy a response. One example of this is we were able in the fall to deploy a team up to the North Bronx using the Mental Health Service Corps to get out 1,200 kits at 9 different substance use programs within a very rapid period after detecting increases in the North and Mid-Bronx. Another effort which we have been conducting for some time, but the new resources with Healing NYC will allow us to do this in an ongoing fashion. Our goal here is to prevent unnecessary exposure to opioids and thereby preventing new cases of addiction or substance use disorder. We issued guidelines some time ago in which we advise prescribers to use opioids less often for shorter durations at the lowest effective dose and not co-prescribe with benzodiazepines, medicines like Valium or Xanax. We have conducted and found effective one-to-one educational visits or prescriber detailing. We're now underway as we speak in Brooklyn, and we are aiming to reach about 1,000 prescribers. We've reached about 900, and we have another few weeks of the campaign going. Very excitingly, we were also awarded additional resources to set up a non-fatal overdose response system. And we are entitling the new program Relay. The health department are hiring wellness advocates who are peer educators to go to participating emergency departments when we are notified about somebody coming in after a non-fatal overdose. The wellness advocate will meet with the patient, with the individual, offer support, risk reduction messages, naloxone, and offer to follow up the individual for up to 90 days with the idea to connect to other kinds of services that the person is interested in. Our aim is to go into 10 hospitals over the next really 2 years at this point. Our first wave is happening this month. We are already launched in Upper Manhattan at Columbia Presbyterian. We've taken the first few calls. Very, very excitingly, and we will be launching in the Bronx at Montefiore Medical Center and Staten Island by the end of the month. As I mentioned, we'll be undertaking a series of public awareness campaigns. This is our I Saved a Life campaign, which just launched. You might have, if you've taken the subway in the last few weeks, or last week, you might have seen this series of 6 ads that are a series of real-life people who describe their use of naloxone to save somebody's life nearby. We are also working hard to expand access to medication-assisted treatment, specifically buprenorphine and methadone. And so for those of you who are not following this with the same avidity as me, why focus on that? So we know from very good multiple randomized controlled trials and systematic reviews that medication-assisted treatment is the most effective way of treating an opioid use disorder compared to treatment without medication. It has been found in study after study to improve a variety of health outcomes, including decreasing mortality, decreasing drug use, regaining of ability to engage in one's other parts of one's life, like employment, family relationships. It also has been found to decrease healthcare costs. And the slide, the graph in front of you, shows that more patients avoid relapse, as by way of example, on buprenorphine maintenance than either a quick buprenorphine taper, a medication taper, or even a longer-term 3-month taper. So we are aiming to improve access to medication-assisted treatment, and here you have our new brochure for buprenorphine, or BUP as we call it for short. We have funded 7 safety net health centers to implement buprenorphine treatment using what we're calling a nurse care manager model. We are supporting centers to hire a nurse care manager to support patients with substance use disorders in or thinking about entering treatment. We are, with the new resources, we'll be expanding that to 14 centers in fiscal year 2018. We are also training, seeking to train 1,500 MDs and more recently nurse practitioners and PAs who are recently allowed to prescribe buprenorphine according to revised federal law. We have that number is greater than 200. The number now is about 300 trained. And then because we know training is not sufficient, we have a team to offer implementation assistance so we can go into practices, support other kinds of staff, help with workflow, and help with working out many of the logistics that accompany starting to prescribe buprenorphine. And that's it.
Thank you, Dr. Cunnins. Are there any, we're very proud of this work, but one thing that Dr. Cunnins didn't mention is that Staten Island, as you saw, has a very high rate of opioid overdose mortality, but they were the borough that showed us that we can bend the curve. They bent the curve on prescription opioid deaths. Unfortunately, heroin, as you saw, has far outtaken prescriptions, but we know that we can bend the curve. We want to bend the curve and see it go down, and we think that this package of interventions will play a big role in that. Any questions or comments from the board? Yes, Dr. Klitzman.
Yeah, thank you for a terrific presentation and all the work you and your colleagues are doing to change the course of this preventable epidemic. I wondered if you could provide us with a little bit more information on what the focus is of the provider intervention. Is it to find alternatives, to be more conservative about dosage and refills? Is there any involvement with drug manufacturers?
So part of our message is to help support prescribers with very concrete steps. So for example, we are aware that for acute pain, prescribers often might offer prescriptions for 2 weeks or a month when best practice is really many fewer days. And I'm guessing the board will also be familiar with the unused prescription bottle that sits in somebody's medicine cabinet and then available for use by somebody else or misuse by somebody else. So even very small practice changes. We also offer something called a morphine milligram equivalent calculator, which sounds sort of technical, but that helps prescribers calculate what the doses that they're actually offering to patients are. Recommended dose above which the threshold becomes riskier for overdose is 100, for example, and so we are giving practical advice to reduce that dose. So it's even without seeking alternatives for folks who might need chronic pain management, we have found that for acute pain or for higher dose prescriptions, there are very easy steps that people can take in addition to recommending alternatives to opioid prescribing. The other thing I'll add, in our campaign, we also offer information about diagnosing and referring patients who maybe have a substance use disorder. We are also advising prescribers to offer a naloxone prescription or a referral to a community setting that has naloxone.
Thank you. And are you, or how are you evaluating the impact of that and your other interventions?
So evaluation is very important to us, and the commissioner just alluded to our Staten Island work where we evaluated a suite of interventions, including a similar detailing campaign, using sort of the gold standard, of course, is mortality data, and really wanting to see the mortality rates come down. less, I would say, ambitiously, but extremely importantly, we also can track prescribing rates using a state database prescription drug monitoring program, and so we will track before and after per capita rates of prescribing in the area that we're doing education, dose changes, sort of the median morphine milliequivalent dose, which I just mentioned, as well as the length or days supply of prescribing.
Dr. Raju.
Just a kind of a point. This is probably, we would have, the providers in the hospital system may have contributed to this inadvertently because of the fact. One of the major factors in the patient experience and satisfaction score is determined by the pain management. So everybody wants to get the highest ranking. Would you recommend the hospital or do you recommend the services to somebody? Then that depends on how pain-free you keep. So we would have probably inadvertently contributed to this in a way. We want to keep our patients totally pain-free at some point. So we tend to discharge them with a large number of large prescriptions with many days in hand, and people don't use it all the time. So I think the future is, as maybe Commissioner or other people should really advocate for this at the federal level, that as a Center for Medicaid and Medicaid Services, we basically come with these metrics. We need to have collateral damage sometimes to these benefits. Because this has been going on for about 5 years. Every hospital wants to get the best scores possible because they want to be in the highest level of patient experience. But it is the only way the patient experience corresponds is to give them paid medicine. And so I think this is something we need to watch out for as we go into the future. Because some of the things look great when you first put in there, but they have enormous collateral damage and benefits. We have seen this in this space. Again, compliment you and commend you for what you have done, and wish you all the best.
Thanks, that's a really helpful comment. We'll pursue it. Ms. Redlin.
Thank you.
Anybody on this side?
It's such an interesting presentation and so important. Since I am not a physician, I just have a little question about naloxone intervention and the campaign which talks about how a common person has saved a person's life. Is there something about having naloxone on hand if you have someone at risk in your family of using medications? And that is the point that we want to encourage common people to understand their potential ability to intervene?
Yes, I think that's exactly the point, which is that so just by way of a little more background, naloxone is very easy to use. It's now, the form that we're now distributing is available in a nasal spray. Naloxone has no adverse consequences or any consequences at all for somebody who does not have opioids, whatever kind, whether prescription painkillers or heroin in their body. And the intent of the message of this series of campaigns is how easy it is to use and to save somebody's life, whether it's a friend, a family member, whether or not you yourself happen to have a drug use problem or involved with drugs. And so we are trying to destigmatize the use of naloxone and the ease of use of naloxone.
So what is the mechanism for getting naloxone, having naloxone in your family, medicine chest?
Great question. So right now in New York City, mostly under Dr. Bassett's standing order, there are approximately 740 pharmacies where you could walk in as just any New Yorker and say, I'd like naloxone. You don't need a prescription because the de facto prescription is from the health department or Dr. Bassett specifically. The medicine is available in all the major chains now under standing orders. That includes CVS, Rite Aid, Duane Reade, and Walgreens. One of the additional resources that Healing NYC is made available to us is our ability to work with pharmacies in an ongoing fashion to sign up additional pharmacies to continue to do pharmacy education. In addition, most insurance companies, I think nearly all at this point, commercial and public, pay for at least one formulation of naloxone, so it will be covered under one's insurance with a copay. In addition, if that's not possible for an individual, we have many community-based programs all across the city, and one can call them and figure out when the next training is and go there. And that's all available in our app. If you go to the end of the app and click the Find Naloxone, all of this information will come up.
And, I'm sorry, just one more question. So community-based providers, community health centers, federally qualified health centers, all are sort of encouraging families to be aware of this treatment and have access to them.
We would like them to be, and we are working with many health centers and social service organizations to consider becoming what's called a registered opioid overdose prevention program, which is a state program, very easy to sign up. And then with that registration and a bit of technical support, they can train their clients or patients and give out kits of naloxone, which we would supply.
Thank you. Very interesting.
Thank you, Ms. Gill.
I wonder whether among the community-based organizations, the department has reached out to the supported housing providers, because for supported housing providers who are providing services to persons living with HIV, mental illness, and substance abuse. And those providers should have those kits available.
Yes, and we are working with a number of housing providers and will continue to do so.
If I could just comment, the leading cause of death for people who are in our homeless system is now overdose. It used to be heart disease, which is the leading cause of death for our whole population. And Dr. Conant's group is working closely with DHS to ensure naloxone availability in our shelter system. Dr. Richardson, did you have a comment?
I did briefly. I just wanted, again, to commend the important and creative work. I was particularly pleased to learn about the non-fatal overdose program that was dispatching wellness advocates to emergency departments. As I may have commented before in the past, I think the emergency department is an often overlooked venue for partnering on various public health initiatives. And I would encourage you to think about it again as perhaps a very appropriate distribution point for naloxone kits, and so you might expand the partnerships that you form with some emergency departments in New York City on the work you're doing.
We agree, and we are pulling a group actually of emergency department physicians together to speak about ways EDs might be involved with this effort, including distributing naloxone, including considering buprenorphine induction for folks coming in withdrawal or seeking services, and of course that needs very close connection to ongoing care.
Ms. Redmond, you're really...
Sorry. One quick question. My son is an emergency medicine physician and head of EMS at one of the hospitals here in the city. So I'm just wondering if the EMS system is also obviously actively
Forever,
Forever.
Always.
Anybody found unresponsive on the street is administered naloxone.
Got it. Thank you.
We don't know how many of those are overdose reversals. That's one of the difficulties with their data, but yes. Dr. Kunz, do you want to add to that?
No.
No, but
Send him our way.
Our goal is that anyone who uses or knows somebody who uses, make sure that they have naloxone around. Of course, we have a first responder system, but hardly anybody overdoses alone. And there are people around, and those are the people we want to see having naloxone. So Dr. Kunitz has really led a charge. 100,000 doses of naloxone is a big number, but we are definitely ramping up. So I want to also highlight the critical importance of stressing the need for treatment and for getting past the notion that people are only clean if they're abstinent. This is really a very bad misconception. All right, so thank you all for a very packed board meeting and for all your many questions and comments. As ever, it is a great honor to have you as our Board of Health. Thank you. We are adjourned, and then he gave me Robert.